Well, thank you very much. Thank you very much to ECIO for this kind invitation to talk about chemosaturation and its role in the management of liver tumours. What I'm hoping to do is to get over the main characteristics of the treatment, to look at how it works, to understand its safety and efficacy and to see how that's changed over time, and then to look at where we are in terms of current data. So in terms of background, the technique of isolating the liver was actually developed as a surgical technique. You can imagine to isolate the liver from a vascular surgical perspective is a major undertaking, but they were able to show quite eloquently back in the late 90s that actually they could establish very good disease control within the liver with this treatment, the issue being it was a once-only treatment. What's changed has been the ability to reproduce the treatment and therefore to repeat the treatment. And we can do that by making this a minimally invasive therapy. And to do that, we need to isolate the liver. So we isolate the venous return from the liver. So you can see here balloons in the right atrium, balloon in the IVC, venous catheter with fenestrations between. That's going to suck all the blood that's coming out of the hepatic veins. We can saturate the liver. We know we can do that with arterial isolation of the liver, just as we do with SIRT or with other embolic therapies. The clever bit is, having sucked the blood out of the hepatic veins, it then goes through a vena-venous bypass machine, and we can then put it through a filtering circuit to clean the chemotherapy out. So the chemotherapy is exposed in large dose to the tumours in the liver. The amount that gets back into the systemic circulation is very low. In terms of exclusion criteria for the treatment, this is basically for people with good performance status, so ECOG 0 or 1, and we try and avoid anyone that has a predisposition to cardiac toxicity from the therapy. So patients will undergo pre-treatment echoes if there's a concern about their fitness level or CPET testing. The other group that we're very cautious are those who are at risk of bleeding disorders, because you need to be fully heparinized to go on the circuit. In terms of liver disease extent, be careful of anyone with greater than 50% replacement of the liver disease. And I think that's for two reasons. One is that most treatments are futile in that setting, but the second is clearly there's a risk of major toxicity if someone has got very extensive disease. We're going to be talking about chemosaturation. So the major indication currently, and the FOCUS study trial, relates to malignant melanoma. So I just thought I'd stop for a second to make it clear that while they are derived from the same tumor cell, the melanocyte, cutaneous and ocular melanoma have very different biologies. Cutaneous melanoma managed by surgical excision, so you have a lump on your arm or your leg, that's resected. As we know, cutaneous melanoma spreads almost directly and always to local regional lymph nodes. And once it's got beyond those local regional lymph nodes, it spreads almost anywhere in the body. So liver-only disease in cutaneous melanoma is very rare. The other thing to know is there are now good treatments with immunotherapies with checkpoint inhibitors for cutaneous melanoma. That's completely the opposite with ocular melanoma. So ocular melanoma is a much rarer tumor, about 5% of melanomas. And what's important to know is the globe of the eye has no lymphatics. So once an ocular melanoma spreads, it spreads hematologically, but 90% of patients present with overwhelming liver disease burden with metastases. They don't present with any other mets. So managing the liver disease is critical to their survival. Where do you get the primary? Most are choroidal, so in the posterior chamber of the eye. Some develop in the ciliary body or the anterior chamber, so in the iris. The symptoms are vague, flashing lights, blurred vision, often asymptomatic and picked up by ophthalmologists. The treatment of the primary is fairly straightforward. There are three basic treatments. Radiation treatment in terms of plaque radiation, so you could put these iridium or tantalum, these iridium markers actually alongside the tumor in a little capsule. You can shine proton beam at the tumor, or if the tumor is extended beyond the globe or is causing local complications, you can enucleate the globe. None of those things make any difference to survival. When we look at survival, survival comes down to the chromosomal anomalies and the cytogenetics. So there is a scoring system, the Liverpool scoring system. If you put in the evidence that we have in terms of monosomy 3 and other chromosomal anomalies, it'll tell us the risk of the tumor coming back. And it's worth noting the tail of the tumor occurrence goes out beyond 10 years. So if you're a high-risk patient, you need screening. You probably need MR done every 6 months to look for liver disease. Pattern of liver disease, even more so than most tumors we treat, there are 2 patterns. If you get this nodular pattern, they treat very well. Even with SIRT or TACE, we've got good results in this group of patients. If you get this widespread, I call it the measles, small volume, difficult to pick up on MR disease, but very extensive on angiography, these patients do very badly, whatever treatment you advocate. So in terms of the treatment, we do a standard isolation of the liver, block the GDA, block the gastric, we think is essential. Then you heparinize a patient, so you fully anticoagulate them, ACT of 450. So it's that balloon that's the clever bit of the kit that allows you to isolate the hepatic veins between these 2 balloons. So what we do then, we put the catheter right up into the right atrium, we blow it up, we then pull down hard so you impact it into the hepatic vein ostium, so then you stop in caval flow from below. We then put another balloon below the hepatic veins to stop flow up the IVC. And then we need to demonstrate we've got occlusion. So we turn the bypass off, we inject hard backwards to the fenestrations. And if you pacify the hepatic veins like that, and you see no leak into the heart, then you know you've got good isolation. So you've fully anticoagulated your patient, you've isolated the hepatic veins, you've got your arterial catheter in there, ready to treat. So we've now isolated the hepatic veins and allowed the blood coming out of the patient to go through the filtering circuit when we're ready. The things to note is there are 2 little drops in blood pressure. So we drop when we drop the IVC return because of the balloons. We also get a sort of SIRS type response when the filters come online, another hit. Now we know about this, and we know how to manage it with inotropes and with beta blockers. The risks of this are fairly small and limited. You can get quite a lot of arterial spasm, so you need quite a lot of GTN sometimes to get good flow. Once you've re-established good flow, you've got hepatic vein isolation. So we're happy that we're in a good place. We then infuse the chemotherapy, which is dissolved in saline using an angiographic pump. So we use melphalan, which is an alkylating agent. We use 3 milligrams per kilogram, which would be a completely myeloablative dose if it got into systemic circulation. But obviously it's not going to, because you're going to be capturing that melphalan and removing it with a filtering circuit. These patients now just go back to surgical recovery, so no need for intensive care or level 1 beds. They go home after a couple of days. Once they're home, we do weekly full blood counts to keep an eye on their platelet count, because there's a risk of toxicity from the chemotherapy. We then follow them up with routine imaging. In terms of what's the right treatment schedule, we still don't know. In the FOCUS study, we were treating patients with 6 cycles of treatment 6 weeks apart. So that seemed a very invasive and very intense cycle of therapy. But every patient we recruited to the FOCUS study in Southampton sailed through those treatments. So there was demonstration within the trial that that was a tolerable amount of treatment, and patients' performance status weren't affected by it. The data, this is the original trial from about 10 years ago, mostly ocular melanoma, some cutaneous melanoma, randomized trial. The problem with the trial is patient in the best alternative care arm, 55% of them crossed over to ever have the active treatment. So this is the problem with the original data, is that almost everyone crossed over to have the treatment. The treatment showed patients that didn't get chemosaturation, their progression liver progression-free survival was very short. We could extend that significantly with chemosaturation. The problem is, when it was looked at in detail, there wasn't a survival advantage because of the extensive crossover, and there were risks about toxicity to do with the first generation of filter. Now, I think this is Brailsford and Chris Rosso. The Sky team have made a sort of complete art form of this, making little differences. Little differences add up to big differences. We've done over 300 cycles of treatment, about 100 patients in Southampton now, and we're absolutely convinced that the treatments are much better tolerated. There's much less toxicity, and that's due to little changes we've made to the treatment protocols. In terms of our data, the first set of our data we published with Moffitt, the American group, showed hepatic control in 82% of patients, but overall survival was only 15.3 months. Now, that's still excellent for patients with ocular melanoma, but it was probably affected by the fact that there were very few patients that received more than 2 cycles in that initial data because it was very early data. But a waterfall plot shows in that first data very good disease control, so complete response or partial response and stable disease. There's a small group with unmeasurable disease, but progressive disease is very uncommon in our cohort and still is, as we've got more aggressive with the treatment cycles. Where's the evidence currently? Well, these are all retrospective groups. In terms of survival, we're starting to get median survival out towards about 1.5 years, which for ocular melanoma is a standout figure, well above any other treatment option at the moment. This is our initial data, and obviously you can break patients down according to their disease burden, according to their biochemistry, and of course their responses. People who respond obviously live longer. What we want to know is what the focus study shows. Well, the focus study is a study which has been run between North America and Europe. Southampton was the second biggest center. It was initially a randomized trial, but then we couldn't get patients to recruit because patients didn't want best alternative care. They weren't allowed to cross over. So then it was changed via the FDA, and it was allowed to be a non-randomized trial. Primary endpoint, objective response rate, then secondary endpoints, overall survival, disease-free survival, etc., and then safety and efficacy. Closed for data capture, so over 100 patients, beginning of last year. The data's being cleaned at the moment. Sadly, I talked to Johnny Johns, so Clinical Affairs in New York, still not allowed to give any data out. They have put a late-breaking abstract into ASCO, so hopefully we will get some data very soon. In terms of where we're at, interventional oncology is undoubtedly the mainstay of disease control for patients with ocular melanoma, liver disease. And I think most people would agree now that chemosaturation is the treatment of choice for liver dominant disease in these patients. Yes, the focus trial data hopefully will be out at ASCO, certainly will be out by later this year. And it's going to be a big year. So NICE appraisal is due in April. UK and the ESMO guidelines are currently being rewritten. I'm helping with the ESMO guidelines. I know the UK ones are ready to go. So there'll be national and European guidance on the management of ocular melanoma within the next few months. I'll put my email address here. Delighted to chat to anyone who's interested in the technique, and I hope that's been informative. Thank you.